Let's begin with our lecture, and our today's lecture of emergency medicine is altered mental status. First, we will talk about the scope of the problem for the altered mental status. If the mental status is not right, or if the function of the patient is not good mentally, then what is the scope of the problem? The problem lies in different areas of the brain as far as the altered mental status is responsible. So if you see in this diagram, it can be the organic lesion of the brain, like encephalitis, any encephalopathies, or it might be some metabolic abnormalities leading to altered mental status, or poisoning. Different chemicals can cause altered mental status, or it can be due to the electrical the activity or electrical transmission is not functioning properly in the brain, or it might be due to chemical imbalance. So as far as the scope of the problem is concerned, in patients with the altered mental status, the problem lies in different regions of the brain, whether it might be the functional problem, it might be organic problem, it might be psychiatric problem, or it might be the problem due to electrical conduction problem, like in patients who have epilepsy, seizures. So different problems can be associated with altered mental status. Different terminology that can be used in patients with the altered mental status. We have level of consciousness. Level of consciousness is the responsiveness of the patient to different stimuli. If the patient is conscious or fully alert, patient will be responsive to different stimuli. But if the conscious level is low, or it's a patient is unconscious completely, then there won't be any response. So one common term that is used in relation to altered mental status is the level of consciousness of the patient, which is also known as the responsiveness of the patient or alertness of the patient, we can say. So after the level of consciousness, other common terminology is the lethargy of the patient. And then the lethargy can be mild to moderate depression. That's the lethargy. When we say the patient is lethargic, it means patient have mild to moderate depression, and in this lethargy we cannot label it as severe depression. So mild to moderate depression is the patient is lethargic. That's another term used for the altered mental status, or the level of, or mental, we can say mental abnormality or mental alertness problem. So lethargy, mild to moderate depression. Third term is stupor. Stupor is more profound depression. So now we know lethargy. Mild to moderate depression is lethargy, or patient is lethargic. Stupor is more profound depression. Patient is so depressed they are not willing to do anything. They have a feeling of worthlessness. They are totally isolated from their circumstances. So that's the profound depression. Lethargy, we can say lethargic phase is common in patients. In even normal individuals, we have phases when the person feel mild to moderate depression. That's the, we can say, the normal part of the life to feel depressed once in a while, and this type of depression is more like lethargy or mild to moderate. But when it reaches to stupor or more profound depression, then that we can say is a pathological condition, and usually it might be a psychological problem also. Then again, another term now is coma, which is deep unconsciousness state. If the patient is in coma, they are unconscious, no alertness, no consciousness, no responsiveness. So common terminologies used very commonly: level of consciousness of the patient, lethargy, stupor, and coma. Mild conscious level of consciousness if they are responsive, lethargy mild to moderate, stupor profound, and now coma, patient in deep unconscious state. Some other terminologies which are used is delirium. Patient is delirious. Again, delirium is also, we can say, its level of alertness or consciousness, or patient, when the person is delirious, they are little disoriented to the time and space also. So delirium. Then abulic state. Abulic state is they are not in a state of making decisions. So they are not capable of making decisions or deciding what to do. So that's also a terminology used in patients with the altered mental status. Acute psychosis. Acute, we know, is the term for the short period and rapid onset of psychosis. Acute psychosis. Psychosis is a condition in which patient has hallucinations, and these hallucinations and delusions, they can be auditory hallucinations when they hear things which are not real. They have visual hallucinations when they see things which are not real. Both are common. Auditory hallucinations are more common in acute psychosis as compared to visual hallucination, and the patient might have illusions also. So these are this is acute psychosis. Dementia. Dementia is memory loss. One is the senile dementia or dementia of the old age, that is normal with age, progressive, but the dementia which is not associated with old age, that's the is the forgetfulness or memory loss. Then we have locked in syndrome. This locked-in syndrome is usually we have there is a stroke as a result of involvement of brainstem, and the brainstem, we know it's midbrain, pons and medulla. So whenever there is a stroke as a result of the abnormality of the lesion in the brainstem, this is known as locked-in syndrome. So all these terminologies very, very important as far as altered mental status is associated with, because psychosis can cause altered mental status, dementia, delirium, abulic state. Then we have condition, a level of consciousness. Then we have stupor, and then the coma. All these are different terminologies very commonly used in patients with the altered mental status. In this slide now, we will go over the comparison between some features of delirium and dementia. First, organic versus functional disorder. So, organic versus functional. Organic, when there is some pathology or there is some lesion present, and functional is without any pathology or any lesion. So, in both conditions, delirium is an organic disease, and dementia is also an organic disease. Then onset and course of the delirium and dementia. The onset of delirium is hours to days, and it has fluctuating course. So it's not a constant symptom or condition. It is fluctuating. It has period when it's really very serious or severe, and then it comes back to the normal. Patient feels normal. So delirium has hours to days of onset, and the course is fluctuating. And then there is in dementia, it's months and progressive course. So it's progressive, slowly it becomes worse, and it's not fluctuating. Then another important is consciousness and orientation of the patient. What's the level of consciousness in delirium and dementia, and whether the patient is well oriented to time and space or not. So consciousness and orientation in delirium, patient has altered consciousness and orientation. Delirium patient has altered level of consciousness, and they are not well oriented in time and space. And then normal consciousness but altered orientation in dementia. Then hallucinations and signs, vital signs. Hallucinations, we have visual hallucinations are present in delirium. There is patients see things which are not real, and then we have variable vital signs. And then in dementia, there are no hallucinations, normal vital signs. Dementia is mainly a progressive disorder. Usually, as the age progresses, the dementia develops. And this dementia of old age, usually these people have very good memory of a long time past, but they usually forget the things that happens really in the short period of time. So they forget the recent things that happen in their life, but they remember the a period of their when they were young and they were children. So the past memory is good, but the recent memory is lost. So all these are differences between the condition delirium and dementia, and both these conditions are associated with the altered mental status. Then we have some miscellaneous. Extreme agitation is common in delirium, and it's reversible in more than 80% of the cases. As far as dementia, usually consider medications, thyroid disease, and infections. So different conditions can cause, miscellaneous conditions can cause delirium and dementia. Next, acute psychosis. Acute psychosis is a functional disease. It's not organic disease, it's a functional disease. Hours to days of onset. Acute psychosis is a condition that is common sometimes after some medicines. It can cause acute psychosis, and once the medicines are withdrawn, the psychosis get better. Sometimes some metabolic conditions also cause acute psychosis. Depression can cause acute psychosis. Then we have psychiatric illness, schizophrenia can cause psychosis. So these are all the conditions that can cause psychosis. And in this we have hallucinations, delusions, illusions, all these are present in acute psychosis. So the onset is hours to days, sometimes within hours after some drugs, medicines or condition, the psychosis develop, or it can be after few days. Auditory hallucinations. Patients hear things which are not real, so they usually hear things, and then they believe that what they are hearing is right. And when people tells them that it's not true, usually they don't believe them, and they become very aggressive and agitated. So these auditory hallucinations are common in acute psychosis. They have normal level of consciousness. Consciousness is not altered. They have alertness is there. Level of consciousness is normal. Only they have hallucinations, and it occurs hours to days after. It can be within hours to days. Fixed delusions. They have fixed delusions. Delusions are false and firm beliefs. Usually they believe somebody is trying to harm them. They are afraid that somebody will harm them, or people are spying on them. So all these delusions, and they have a strong belief on these things what they think. First attack is usually in patient less than 40 years of age. So acute psychosis have auditory hallucinations, delusions. Patient is usually young patients less than 40 years of age, very common in the adolescence age, about less than 25 years, when there is different changes are going through their life, like hormonal changes, and it depends on the hormonal changes and on the circumstances and environment. Next, what are some red flags of altered mental status? What are some conditions we should pay attention to, and that raise the suspicion that this patient might have the problems associated with altered mental status? Polyuria, polydipsia, and polyphagia. So people who have excessive urination, they drink a lot, and they are eating a lot. All these are the red flags. And cancer with recent chemotherapy. In this polyuria, polydipsia, polyphagia, they have hyperosmolar and hyperglycemic state. This is very common. Polyuria, polydipsia, polyphagia is important characteristics of patients who have diabetes, and they have high glucose levels, so hyperosmolar and hyperglycemic state. And also diabetic ketoacidosis, all can cause these polyuria, polydipsia, polyphagia, and these metabolic abnormalities can cause altered mental status. Sometimes patients, you see in emergency department, Patients come and they are in coma, they are unconscious. When you do their blood glucose level, their glucose level is really high, 2000 or 800, and they had no idea that they have diabetes. So this is a very common condition leading to the altered mental status. Opportunistic infections are the infections which which do not occur in the normal healthy individual with normal immune system, but people who are immunocompromised or immunosuppressed after the therapeutic drugs, or in patients who have AIDS. These opportunistic infections are common, and these opportunistic infections can also cause altered mental status, and very common in patients with a history of chemotherapy after the diagnosis of the cancer. Then tumor lysis syndrome and hypercalcemia. When there is increased level of calcium, and tumor lysis syndrome also have high calcium level. Hypercalcemia also is a condition that can cause altered mental status. So these are some red flags. Patients with the history of known history of diabetes, or patient who have no known history of diabetes suddenly visit the emergency department with hyperglycemia, with diabetic ketoacidosis, and they have altered mental status or the complete loss of consciousness or the coma. Then the cancer-related tumor and neutropenic fever. So again, cancer-related tumor and neutropenic fever. When they have neutropenia, again, neutrophils are the cells responsible for the immune system, for killing the microorganism. When there is neutropenia, usually as a result of chemotherapy, chemotherapeutic drugs, they affect the bone marrow and they cause decrease in the neutrophil levels. Neutrophils are very important white blood cells which fight against the infection, and when that is low, in different infections are there, we have opportunistic infections are there, and this can lead to the altered mental status. Some other red flags are the fever, chills, rigors. If there is a recent history of fever, chills, rigors, different infections associated with fever, chills, and rigors. We have infections like bacteremia, septicemia, and sepsis. Remember all these: septicemia, sepsis, bacteremia. When the bacteria reaches the bloodstream and they cause sepsis or septicemia, it's a very, very high mortality rate condition associated with high mortality, morbidity, and there is patient with fever, chills, and rigors. Once the septicemia is present, there is spread of infection in the bloodstream, and through that it reaches the different parts of the body, and it can cause acidosis, and it can cause hypoxia, ischemia, causing the necrosis and death of different tissues, and slowly this can cause multi-organ failure, and it can cause end-stage multi-organ disease and cause death due to renal failure, hepatic failure, and different conditions. So whenever there is fever, chills, rigor, history of infections, suspect that there is septicemia and bacteremia present. pneumonia, UTI, and meningitis. Again, so all these conditions, all these infections present with fever, chills, rigors, and all these infections are serious and they affect the brain and they can cause altered mental status. Next red flag is very important. We can say one of the most important is the head traumas. Head traumas can cause altered mental status. So if there is a history of head trauma, that is a red flag that should raise the suspicion that the patient might have the problem. And as a result of head trauma, if there is concussion or contusion, immediately after the head trauma, sometimes with concussion, patient is completely normal, but after some time, there is a level of consciousness is affected, it is low, less, and then a person can completely become unconscious because of the bleeding and hemorrhage, and it can cause pressure, and increase pressure can cause loss of consciousness or altered mental status. Post-traumatic seizures and hemorrhage. So all these can occur as a result of head trauma. Another red flag is intravenous drug use, IV drug users. IV drug users, patients who are drug abusers who use the street drugs like heroin, cocaine, this can very commonly cause complications like endocarditis, epidural abscess. Endocarditis is the inflammation of the endocardium of the heart, and we have endocardium layer, myocardium, and the pericardium. So endocardium is the inner layer of the heart, and it becomes infected and it can cause endocarditis, and there is murmur present of endocarditis, and there is also epidural abscess. So all these are important red flags associated with the altered mental status. Diabetes, as we mentioned already, there is hyperglycemia, patient has polyuria, polydipsia, polyphagia. So diabetes, hypoglycemia, both have effect on the mental status, alertness of the patient, can cause the coma and complete loss of consciousness. So if the patient comes to the emergency department and hyperglycemia or diabetic ketoacidosis, these patients have special breath odor also, but right away take the blood sample and do their blood glucose level. If the blood glucose is very low, it's a hypoglycemia can also occur in patients who are on the insulin, and if the dose is high or if they didn't eat on time, usually they have hypoglycemic coma, and the immediate glucose should be injected, and usually it causes rapid alertness or awakening of the patient. So in diabetes, both hypoglycemia and hyperglycemia can cause altered mental status. Then new or change in medication. Change in medications also is one of the, we can say, very common factor or red flag that should raise the suspicion that medicine is or some drug is causing the problem. It can be due to the interaction between one or two drugs, or it may be due to the adverse reaction of the drug. Antidepressants, even they are used to treat the depression. Initially, they have a very strong effect and they can cause acute psychosis. So change in the drug or different drugs can have effect on the mental status. Recent travel abroad, and this is very important in condition areas where some infections are endemic, like river valley. Histoplasmosis is common in some areas. We have typhoid common. Some parts of the world we have malaria common. So all these infections, if there is a recent history of travel to the area where these infections are endemic, it raises the suspicion that it might be the cause of the altered mental status. Then some recent history of recent surgery like post-operative infection, malignant hyperthermia. So malignant hyperthermia, high temperature after surgery, or it can be post-operative infections, very common. The wound get infected. Infections are common after surgery if it is not performed under complete sterile conditions. Usually antibiotics are prescribed as a routine to prevent these infections, but there are sometimes cases associated with infection. So all these are very important red flags. Change in medications or new medication at all, infections, recent history of travel, post-operative infections, diabetes, all these are the red flags that increase the suspicion or raise the suspicion that these might be the cause of the altered mental status. History. In history we should know what was the timing and course of events since onset of change in the mental status. Again, it's very important. History should be taken if the patient is alert and they are well oriented. They are the one we should ask what was the circumstances in which the altered mental status occur. If they say, I changed the medicine, I changed the drug, or I had head trauma a day before, or I am a patient with diabetes, all these are, or I had a surgery about 4 or 5 days ago. All these are important in the history. Or if the patient is unconscious, anyone close to the patient who knows the patient very well, they should give the history. Or somebody, if it's outside the house and some unknown person just bring the patient to the hospital or emergency department, we should ask those people also that what were the circumstances in which this happened. Then what methods physician can use to overcome difficulties obtaining detailed history from the patient. So if the patient has altered mental status, level of alertness is not good, then the different methods are adopted by the physician to get the proper history, because the proper history is very important to reach the final diagnosis, what is the cause of the altered mental status, and then we should plan how we will manage the condition and manage the patient accordingly. Physical examination of the patient with the altered mental status, vital signs. Elevated temperature indicates infection. Usually infections are associated with fever or high temperatures. Without the fever, usually the infection is excluded. So infection is usually associated with high temperature. Then the temperature of more than 106 degree Fahrenheit is usually due to heat stroke. ECG and heart rate tells about the toxins. Elevated blood pressure, widened pulse pressure. Pulse oximetry again gives us the cause of hypoxia. Very high temperature drug interaction. So all these are the findings on examination. We should look for the blood pressure, pulse, temperature, oxygen level by the oximetry. That gives us that patient might have hypoxia, and then we should look for the causes of hypoxia. And very high temperatures above 106 usually may be due to the heat strokes, and then management should be done for the heat stroke. Head examination of the patient with the altered mental status. Breath odor examination. In this breath odor examination, again, diabetic ketoacidosis, they have a fruity odor because of high glucose level, and also in liver failure, the breath odor examination should be done. And insecticides, toxins, arsenic, gasoline, all these different chemicals that can be used for the suicidal purposes, or by the accidental ingestion of these can cause the problem. So that's breath odor examination should be performed in these cases. Then also the head examination for any sign of trauma like hemotympanum, presence of blood in the tympanic cavity. Then I look for any past surgeries, any shunts, any scar. So these are the important examination through the breath odor, and then by the examination of the head. Eyes examination, pupillary exam. Pupillary exam is usually for the structural abnormalities and metabolic abnormalities. Eye movement and eye tone is for organic disease and hemorrhage. Then fundoscopic examination for flame, hemorrhages, and papilledema. So for altered mental status, eye examination is also very, very important. Transtentorial herniation from blunt head trauma, and this eyes examination is also helpful. Epidural hematoma with acute mass effect. Epidural hematoma, collection of blood in the epidura below the here. Dura, we have, these are the layers of the meninges. We have dura mater, pia mater, and arachnoid mater. So epidural hematoma. Then early papilledema with disc elevations. Next, oculocephalic reflex Doll's eye test. This is also important, unimpaired. In unimpaired oculocephalic reflex, what happens when the head turns to the right, eyes turn to the left. Head turn left, eyes to the right. This is unimpaired oculocephalic reflex. When it's impaired or affected, then what happens? It will totally change. So in the unimpaired, head turn to the right side, the eyes moves to the left. In this head turned right, the eyes are fixed. The eyes are not moving to the left side. And then when the head turns left, again the eyes are fixed. So it's the impaired oculocephalic reflex. Oculovestibular testing. This is done by the caloric test, by the change in the temperature, and ice water irrigation in right ear. So ice water irrigation in the right ear, it causes alert wakefulness. That's the response if it's alert and wakefulness. In condition when there is bilateral cerebral hemisphere dysfunction, then in this case you can see there is deviation of the eyes to the side. In left dysfunction, we have one turns to the left and the other eye is in the center. In pontine dysfunction, both are not moved. So that's how we do the irrigation with the cold water and look for the movement of the eye that tells us different abnormalities like bilateral cerebral hemisphere dysfunction, pontine dysfunction, and MLF dysfunction. Next, cold calorics. Cold calorics, what's the response and how we interpret that response of cold caloric testing? Both eye deviates and there is nystagmus. Both eyes, deviation of both eyes. Nystagmus is involuntary movement of the eyeball. So if these occur, then the interpretation is patient is not comatose. Patient is not in coma. If both eyes tonically deviate towards the cold water, if the eyes deviate, if it's on the right side, they deviate to the right side, it means there is coma but intact brain stem. No eye movement or movement of one eye ipsilateral to stimulus, brain stem damage, internuclear ophthalmoplegia. So very important, all these tests, they help in finding the abnormality. All these different, we have eye examinations and then we have oculocephalic test, oculovestibular test by the irrigation of cold ice water, and then cold caloric in which the cold water is inserted or cold is applied, and we look for these different reactions. Next, physical examination in the neck. What we should look for meningismus, thyroid or parathyroid disease. In the lungs, look for hypoxia, level of oxygen, hypercarbia, increased level of carbon dioxide, pneumonia, and obstructive pulmonary disease. In the heart, we should look for any abnormality in the rhythm, heart failure, valvular heart disease, any development of new murmurs as in endocarditis. Then some other physical examinations, intra-abdominal process and infections and organomegaly. Look for these if there is enlargement of the liver, spleen, heart, if there is any infection. Also, liver failure, severe alcoholics have spider angiomas, ascites, etc. And alcoholism and severe alcoholics have altered mental status also. Pancreatitis, abdominal aortic aneurysm, flank and periumbilical ecchymosis. Rectal we look for any malignancy, blood in the feces, GI bleeding. In the skin, we should look for the skin temperature and hydration of the skin. And then neurologic, we should look for the automatism, any abnormal respiratory patterns. Progressive brainstem dysfunction. Early brainstem compression, usually we have chain stroke respiration or breathing in the early brainstem compression. In the midbrain and upper pons, there is central neurogenic hyperventilation. In pons and upper medulla, there is quiet respiration, normal rate. So brainstem dysfunction, their brainstem has three structures. We have midbrain, then the pons, and then medulla oblongata. So different areas, what are the effect of the lesion of different parts of the brainstem on the breathing. If it's early brainstem compression, chain stroke respiration. In midbrain and upper pons, central neurogenic, patient has high hyperventilating ability. And pons and upper medulla, the quiet respiration, normal rate. And only medulla, it's slow, irregular respiration causing apnea. Then the assessment of mental status assessment is Glasgow Coma Scale. This eye-opening as a result, if we do the mental assessment and then we look for the response of the eyes to that assessment. If it's in one, none, no response. Then in two, the eyes open to the pain. In third, the eyes open to voice. Four, they open the eyes spontaneously. Then verbal response. First, 5 number is patient is oriented, confused, inappropriate words, perplexing sounds, and no response to the verbal stimulus. So 1, no response. 2, perplexing sounds in response to verbal stimulus. Inappropriate words, patient is confused and patient is oriented. Next, motor response of Glasgow Coma Scale. Number 6, patient obeys the commands. Whatever we say, okay, raise the hand, touch the finger to the nose. All those, touch the fingers of one hand to the finger of the opposite hand. So all these motor responses, patient obeys these commands properly. 5, patient can localize. 4, withdraws, decorticate posturing, decerebrate posturing, and none. So all these are the tests which gives us the Glasgow Coma Scale depending on the responsiveness of the patient to the different stimuli, which might be the motor stimulus, verbal stimulus, and the eye opening as a result of the pain or the sound or voice. Again, mental status assessment, AVPU. A is awake and aware. V is for the respond to verbal stimuli. P is response to painful stimuli, and U is unresponsive. So AVPU, very important, alert and awake. Verbal stimuli, respond to verbal stimuli, respond to painful stimuli, and the patient is unresponsive. Then mini mental status examination, confusion assessment method. Cranial nerves must be tested, and also motor and sensory testing. So all these should be done in the mental status assessment. We talked about the eye-opening test, then we talked about different steps of Glasgow coma scale, and then another we should have mini mental test performed. Cranial nerves must be tested. There are 12 cranial nerves. Each have their own specific function, and those need to be tested to look for the altered mental status. Confusion assessment method is also important, and motor and sensory testing. So after the mental status assessment and all the Glasgow coma scale and mini mental status assessment, now we will talk about the differential diagnosis of different conditions which can cause altered mental status. So if we go over A, E, I, O, U, then A is for the alcohol, other toxins and other drugs that can cause altered mental status. Alcohol very commonly associated with the delirium and delusions, hallucinations, and it is associated with the altered mental status. Other toxins also and drugs can cause the altered mental status. Then we have in the E, we have endocrine and electrolyte abnormalities like hyperkalemia, hypokalemia, and then hypercalcemia, endocrine problems like thyroid abnormalities like hypothyroidism, hyperthyroidism, and if we talk about the parathyroid gland, especially hypercalcemia can cause the altered mental status. I in this case is for insulin, and insulin is the hormone produced by the pancreas, and it is responsible for the metabolism of the glucose level, and if the insulin level is low, it can cause diabetes because of increased blood glucose level. So insulin is also important for as far as blood glucose levels are concerned. Then O is for the oxygen level and opiates. Oxygen hypoxia can cause affect different organs of the body, and even hypoxia of the nervous system can lead to the altered level of consciousness and alertness. And opiates, again, the drugs which are abused, and they can cause altered mental status. Then U is for uremia, renal including hypertension. Uremia is the renal failure in which blood uric acid levels gets very high, and there is increased nitrogen, increased creatinine levels, and these are all very toxic to the brain, and they can cause altered mental status. Next, T is for the trauma and temperature. We know, we already talked about this, that the head trauma, concussion, contusion, and hemorrhages occurring as a result of head trauma can cause the changes in the mental status and also changes in the temperature. Hyperthermia and hypothermia both can be associated with altered mental status. Then another I is in this case is infection. very common different infections, malaria, typhoid, all these can be associated with the altered mental status. Now, P is for psychiatric illness and the porphyria. Psychiatric illnesses like acute psychosis, schizophrenia, these can cause altered mental status. Depression, to some extent, also can cause acute psychosis. So, this is also one of the differential diagnoses. Then S in this case, very important, subarachnoid hemorrhage. Sub means under, arachnoid below the arachnoid. Again, we have pia mater, arachnoid mater, which is the middle layer of the meninges, and any hemorrhage or bleeding below the arachnoid can cause subarachnoid hemorrhage, and some masses, space occupying lesions, mass, tumor also can cause altered mental status. Rather, sometimes the first indication when the patient comes to emergency department and they have loss of consciousness, their level of alertness is disturbed, and when the further examination is done, usually they have mass in the brain or in space occupying lesion in the brain. So that's also important. Seizures can also cause altered mental status. So if we talk about just this slide, AEIOU tips, it's AEIOU tips is all the important conditions which comes under the differential diagnosis of the altered mental status. Now after that AEIOU tips, now we will go over the different org structures and how different conditions comes under the differential diagnosis. First, let's talk about the head. In the head, we divided it into supratentorial and infratentorial. Tentorium, usually it divides partition between the cerebrum and cerebellum. So cerebrum is the cerebral hemisphere. We have two cerebral hemisphere. So supratentorial region is the cerebrum or the region above the cerebellum. So in that we have concussions. Concussion, usually after the head trauma, there is slight concussion. Even if there is no presentation immediately after the trauma, patients who develop the concussion of the head, they have altered level of consciousness maybe some time after the head trauma. So concussion, any infection of the supratentorial region, vernix encephalopathy, very common in alcoholics due to the thiamine deficiency, they develop vernix encephalopathy. Then the cerebral vascular accident, CVA. So supratentorial, as I mentioned, supratentorial is the area of the cerebrum. So cerebrovascular accident, when there is bleeding from the cerebral blood vessel and there is hemorrhage, CVA usually cause strokes. Very common cause of stroke is cerebrovascular accident, and it can cause again the altered mental status. There is loss of consciousness or patient is usually unconscious. Subarachnoid hemorrhage, again hemorrhage below the arachnoid matter, which is the meninge of the brain. And subarachnoid hemorrhage, usually it causes changes in the level of consciousness and it causes rigidity in the body also. Then we have unilateral hemispheric disease with herniation. Unilateral is on one side, hemispheric disease, hemisphere. We have half sphere or half portion of the cerebrum. It's not bilateral, it's half of the sphere, half of the cerebrum is involved, and there is herniation also. What is herniation? There is protrusion of one part of the body to the other. So when there is herniation and unilateral hemispheric disease, it can cause also altered mental status. So these are some important supratentorial, we can say the supratentorial lesions or supratentorial conditions that can cause altered mental status. If we talk about infratentorial, or these are the lesions mainly or conditions mainly in the cerebellum or below the cerebral hemisphere, we have cerebellar and pontine hemorrhage. Brainstem is the midbrain, pons and medulla. And then we have the cerebellum. Cerebellum is mainly responsible for the movements, walking. Cerebral lesions cause cerebellar lesions cause abnormalities in the walking, and these hemorrhages also can cause altered mental status. So these are infratentorial lesions. Then traumatic posterior fossa hemorrhage. Any hemorrhage in the posterior fossa as a result of trauma can also cause altered mental status. Basilar artery occlusion, occlusion or blockage of the basilar artery or any tumor in the brainstem. All these are infratentorial lesion. All these can cause altered mental status, and artery occlusion, especially when there is occlusion of the artery, there is no supply of blood, and this hypoxia or ischemia can cause the changes in the mental status. So after the differential diagnosis or some conditions which we divide into supratentorial or infratentorial, then now we will talk about some conditions in the mouth. And mouth conditions usually which cause altered mental status, they are the drugs which we ingest through the mouth, and all these drugs are capable of causing altered mental status if as a result of interaction between different drugs, or maybe sometimes due to overdose of some drugs, they can cause altered mental status. Toxins, any medications, alcohol, opiates, we already talked about them, that alcohol can cause the altered mental status. Similarly with the opiates, they are the street drugs that can cause euphoria, and they affect the brain functioning. Anticholinergic drugs, and then we have drugs used for seizures and convulsions, carbon monoxide. All these also are associated with the altered mental status. Barbiturates, hallucinogens, cyanides. Again, another important drugs that can cause altered mental status. Phenothiazines, salicylates. Salicylates are like aspirin. They can cause altered mental status. They usually affect the ears, and when they have cause problem in the ear, that indirectly can cause mostly in altered mental status. And then sedatives, these are the drugs used for inducing sleep. They can affect the status also of the mental activity. Then sympathetomimetics and tricyclic antidepressant. So as far as mouth is concerned, all these drugs come under the differential diagnosis, but the most important among these, we can say alcohol, very commonly associated with the altered mental status, and then we have opiates, commonly associated with the altered mental status, hallucinogens, and barbiturates also. Then what are the conditions which come under the differential diagnosis in the neck? In the neck we have the glands, we have thyroid gland in the neck, and around the thyroid we have 4 parathyroid glands. So thyroid gland is responsible for the metabolism, and when there is hyperthyroidism, increased thyroid level, it can cause sweating and weakness and tremor, and hyperthyroidism affects the alertness of the body, mind also, and it can cause the weakness and wasting. So hyperthyroidism is increased thyroid level, and opposite to that, hypothyroidism is decreased thyroid hormone level. Post-operative endocrinopathy. Post-operative endocrinopathy after some surgeries, like sometimes when the surgery is performed on the thyroid gland, thyroidectomy, removal of the thyroid, since parathyroid glands are located 4 parathyroid glands around the thyroid gland. So there is accidental sometimes removal of parathyroid gland, and it can cause the changes in the calcium level, and it can cause the altered mental status also. So post-operative endocrinopathies are common. Parathyroid disease is responsible for the calcium level in the between the bones and the blood, and whenever there is changes in the parathyroid hormone level, hypercalcemia especially, it can cause altered mental status, as compared hypocalcemia cause tetany of the muscles. Then some differential diagnosis in the chest and in the heart. We have hypoxia and hypercarbia, very important. Both decreased level of oxygen and increased level of carbon dioxide as a result of ventilation problems. It can cause changes or altered mental status. You can see in this diagram that's it's showing cyanosis. Cyanosis is bluish discoloration of the skin, especially of the fingertips is the earliest point where there is cyanosis due to poor supply of oxygen. Then rhythm disturbance in the heart, arrhythmia. Arrhythmia can cause loss of consciousness also. Pulmonary emboli. What is emboli? Emboli is the blood clot that is dislodged from the thrombus, and it flows in the bloodstream, and it can cause obstruction. And when there is pulmonary emboli, there is ventilation is affected. As a result of poor ventilation, again there is hypoxia and hypercarbia, and it can cause the same mechanism and cause altered mental status. Congestive heart failure is when there is poor pumping of the heart. The heart is failed and there is no proper pumping of the blood, leading to ischemia and hypoxia. So all these are very, very important conditions which can cause altered mental status. The mechanism of all these may be ultimately the same, like causing hypoxia, hypercarbia, and it can cause ischemia, causes different metabolic changes in the body, leading to maybe sepsis, septicemia, and which ultimately can cause spread of infections to the different parts of the body and causing altered mental status. So one condition is associated with another and is very, very closely related. Then in the abdomen, what are some conditions? Hepatic encephalopathy. Alcoholics, they develop cirrhosis of liver, and that cirrhosis of liver can cause hepatic failure, and it can cause hepatic encephalopathy because of all the toxins which are detoxified by the liver. Now the liver is not functioning properly, so they increased in the body. As a result of that increase, the effect on the brain, and it can cause altered mental status, and hepatic encephalopathy is a very serious condition with very high mortality rate. Then in the pancreas are also in the abdomen, which is the gland that produce the insulin. And now we know so well after all this discussion that insulin plays an important role in the metabolism of glucose. So high blood glucose, low blood glucose, both are associated with the level of consciousness and alertness. Then there is renal insufficiency and infection. Urinary tract infection, UTI, is one of the common infections, especially in females because of small urethra. So renal insufficiency, uremia, again have high level of uric acid, increased creatinine level, and they affect on the brain and cause altered mental status. Then adrenal insufficiency. Adrenal are the glands. Here you can see these are the kidneys. These are the glands present on top of the kidneys, and they are the adrenal glands. Adrenal glands again produce very important hormones like corticosteroids, aldosterone, and any increase or decrease in the hormones produced by the aldosterone cause altered mental status, especially as a result of electrolyte disturbance or electrolyte imbalance associated with aldosterone. Then peritonitis. Peritonitis is the inflammation of the peritoneum, which is the lining of the abdomen that has all the organs present, abdominal organs present in the peritoneum. And when there is inflammation or infection of the peritoneum, again, it has as a result, it can cause altered mental status because of high fever, infections, and appendicitis. Same way, all can cause altered mental status. Then in the abdomen, we have blood vessels, involvement of those like mesenteric ischemia. Ischemia or decreased supply of oxygen or blood to the mesenteric artery or vessel. It can cause altered mental status. Abdominal aortic aneurysm, abdominal aorta. In the abdomen, the region of the aorta is the largest artery in the body that carries the blood to from the heart to different parts of the body. So when it goes through the abdomen, and this abdominal aortic aneurysm is the dilatation of the blood vessel. When there is dilation of the blood vessel, there is weakening of the wall of the blood vessel, and that weakening of the blood vessel make it more prone to the rupture or perforation. And when that rupture or perforation occur, rupture of abdominal aneurysm is associated with very high mortality rate, and usually these patients, they do not survive because of massive blood loss as a result of the rupture of the hemorrhage, and cause ischemia, hypoxia, and level of consciousness is affected, and there is unconsciousness. Then another differential diagnosis, conditions in the skin, very important. We know hypothermia, hyperthermia, both can cause the altered mental status. color. Look for the color change. In the liver failure, renal failure, hypoxia, we see different color changes, cyanosis, erythema, all these. In erythema we have redness, in hypoxia we have bluish discoloration, in jaundice due to liver failure we have bluish discoloration of the skin. So all these are the different changes in the color of the skin that gives us the idea about the condition associated with that. Then rash, which is due to vasculitis, thrombotic, thrombocytopenic purpura, and shock. These are all the conditions which can cause the rash, but they are associated with the altered mental status also. Then some miscellaneous conditions associated with altered mental status like sepsis. We already talked in detail about sepsis. When there is sepsis, bacteremia, septicemia, then infection reaches different parts of the body as a result of the blood flow, and it can cause metabolic acidosis, hypoxia, ischemia. Hyperviscosity syndrome. Hyperviscosity is increase in the viscosity of the blood flow. There is increased resistance to the blood flow, and when there is resistance to the blood flow, again it is affected in the blood vessels. Vasculitis like cerebritis, infection of the cerebrum of the brain, can cause altered mental status. Next, some diagnostic tests we can perform for the diagnosis. Since we talked in detail now what are different conditions that can cause altered mental status, it gives us roughly the idea what needs to be tested for the diagnosis. Glucose levels, toxin levels, different drug levels, alcohol levels should be tested to find out the cause of altered mental status. So let's begin. Glucose. We should check the glucose level by the glucometer or by the dextro stick, which is a simple method in which we stick the dip the stick in the urine and check for the glucose level. Pulse oximetry, again very simple test, and it gives us the level of oxygen present in the blood. Breathalyzer ethanol, it gives us the level of ethanol present in, and then it can tell us whether what's the level of alcohol. Hematocrit. Hematocrit is the how much blood is lost. Hematocrit is the level of how the level of the red blood cells. So how much blood is lost, we can tell that by the hematocrit level. It gives the red blood cells. Another diagnostic testing, complete blood count, electrolyte levels to look for calcium, potassium, sodium. Arterial blood gas for acidosis. Urinalysis for infection, any ketosis. These are the dipsticks. You dip them in the urine and it gives us different values. Very effective initial test to look for infection, for ketone bodies, for proteinuria, for glucouria. All these are done for even blood cells, white blood cell count. It gives us the presence of blood in the red blood cell in the urine. So it's the basic initial test done for the diagnosis. Then we have directed drug screening, ECG and cardiac monitor for any abnormality of the heart, to look for the rhythm of the heart. And then chest x-ray is also very important to look for different infections of the which have different pulmonary infections. Head CT, so computerized tomography of the head, peritoneal tap. Peritoneal tap, if in cirrhosis of the liver, there is fluid in the abdominal cavity, that's the ascites or acidic fluid. The removal of that fluid to perform different tests is also done. Thyroid function studies to look for hypothyroidism and hyperthyroidism. Electroencephalogram, MRI, cervical spine x-rays. Lumbar puncture and cerebrospinal fluid analysis to look for the pressure, to look for any hemorrhage in the brain, and the analysis of cerebrospinal fluid to look for meningitis. Now, general treatment principles of the patient with altered mental status: dextrose is given, O, oxygen, N, naloxone, T is thiamine for Wernicke's encephalopathy. Volume replacement, temperature control, flumazenil and physostigmine, antibiotics, neurosurgery. So all these are the treatment options: volume replacement, any temperature control, flumazenil, physostigmine, for especially for the we talked about different drugs that can cause the altered mental status. To neutralize those drugs like cholinergic, we use these physostigmine. Antibiotics to control any infection. Neurosurgery, very important if there is any head trauma, if there is hemorrhages, to remove the bleeding, we should do the neurosurgery. Some special patients, geriatric, old age patient, we have infection, metabolic disturbance and pain. Dehydration, nutritional abnormalities. So in old age, these are the common conditions that can cause altered mental status, because these are not very well nourished people. They don't take care of themselves. They have maybe pain, metabolic disturbance, some infections, dehydration. All these can cause effect on the brain functioning and cause altered mental status. In pediatric age group, common cause is any toxicological, usually any ingestion of toxin by accident is the common cause. Any infection, trauma, again metabolic disturbances. In immunocompromised individual whose immune response is weak, malignancies, and the patients who are on immunosuppressive drugs. Diseases like AIDS. Disposition of the patient with altered mental status, reversible causes, and clears patient sensorium. So disposition, how the patient will be positioned, depends on if the condition improves and the patient has clear sensorium, cause was reversible, then the disposition is different. And then acute psychiatric evaluation once medically stabilized. Psychiatric evaluation is very important in these patients because most likely they have some psychiatric issues that leads to all these conditions that can cause altered mental status. Diabetics present to emergency department with hypoglycemia. Elderly and immunocompromised patients are more complicated and they need further management and treatment. Next, some pearls, pitfalls, and myths associated with this altered mental status. Consider all diagnosis. Remember the basics A, B, C's, and hydration. Unilateral dilated pupil, posterior communicating aneurysm, and then recognize difficulty in obtaining quality history. So these are some pearls, pitfalls, and myths. One, consider all diagnosis. Since we talked about all these different diagnoses, differential diagnosis, sometimes it's really hard to go over all the diagnoses. So preferably should go for the most common and most whatever the history is suggestive. And in the management of the patient, consider the ABCs: airway, breathing, circulation, and hydration, and try to get the best history. So that concludes our topic of altered mental status. Thanks for watching sqadia.com.